And in honor of Child Abuse Prevention Month for April, we're doing a child maltreatment topic this morning. Dr. Jenny Green graduated from the University of Florida Medical School in 2014 and completed pediatric residency at Child Abuse Pediatrics Fellowship training here at University of Louisville. She completed her training in the summer of 2020 and began as a child abuse pediatrician, with the Norton Children's Pediatric Protection Specialist. And she is a staff physician also at the Child Advocacy Center. Her fellowship research involved a review of hospital practices related to children admitted for concern for failure to thrive. Dr. Nick Miles did his undergraduate study at the University of Colorado before earning his medical degree from Florida International University in Miami in 2016. He completed his residency in pediatrics through U of L in 2019 and is currently in his second year of fellowship in child abuse pediatrics with Norton Children's Pediatric Protection Specialists affiliated with U of L. His fellowship research interests include exploring the use of infrared photography in the assessment and documentation of skin findings. So I give you Drs. Green and Miles.
Thank you, Dr. Curry. I really appreciate it. I just want to make sure, is my audio okay?
Yes, ma'am.
Awesome. Okay, so we're going to be talking about failure to thrive and child neglect together, which sometimes can be a little bit of a nebulous subject, especially, honestly, for us child abuse pediatricians as well. So the objectives today are going to be to describe what constitutes failure to thrive, all the myriad of definitions that exist in the literature, understand some best practices just related to evaluation and management, define and understand kind of what constitutes child neglect, what we're looking for, what can make that diagnosis somewhat difficult. And then Dr. Miles is going to go through a series of cases which illustrate some of the essentially evaluation practices that we undergo, and then some of the pitfalls involved with trying to make that diagnosis. Okay, so as everybody probably on this conference who practices pediatrics knows, failure to thrive is one of the most common reasons for hospital admission in kids under the age of 2. Approximately 1 to 5% of all hospitalizations in a peds hospital are related to this symptom, and approximately 10% of all peds outpatient clinic appointments comprise this concern as well. Evidence-based practice does dictate that most infants can be successfully diagnosed with history, physical, and a feeding and caregiver child observation alone, which is a little different from how a lot of programs do things. So this would exclude things like laboratory evaluations, imaging evaluations, subspecialist evaluations, only based upon things that you would derive from the history and physical exam. But since so much failure to thrive is determined to have underlying either psychosocial or potentially neglect concerns, a lot of times those things aren't needed to be able to establish that diagnosis. So I was kind of shocked, honestly. I've always used for kids less than 2 years of age, the weight less than the 5th percentile, but lots of different valid literature suggests that there's actually a myriad of different things you could use to help define failure to thrive. So less than the 5th percentile, up to date has the 3rd to the 5th percentile. One hospital protocol used less than the 2nd percentile. So again, it's good to be on the same page when you have a child, kind of what definitions you're using to establish failure to thrive. And it's for gestation corrected age and sex on the appropriate growth curve. So we know that for preemies, we should be using the preemie growth curve. For kids with Down syndrome, we should be using that specialized growth curve. And for kids with any other syndromes or initial, especially in utero growth concerns, we need to be cognizant of that. And it would involve decreased weight gain velocity disproportionate to length. So the best way to get at that, honestly, is just to look at the weight for length percentiles to be able to determine kind of if there's been a fall off with that as well. Other criteria that can be used, so weight crossing 2 or more major percentile than a downward trend, that one's pretty typical and something that we see. Weight less than 80th percentile, weight for length less than 10th percentile, and rate of daily weight gain less than expected for age. So oftentimes in our infants, we're looking for that 25 to 30 grams per day. As the child grows older, that changes, and UpToDate actually has a great chart that kind of delineates those grams per day typical weight gains for those different ages. I didn't include it in this talk because it wasn't extremely relevant to what I was discussing, but it is available for review. So malnutrition is a diagnosis that we can assign, and some literature kind of proffers that this might be a really a better way to kind of delineate essentially the child's state, especially upon admission. So some of the uses of this would just be obviously looking at Z-scores. And I can tell you that over time, I've grown more fond of Z-scores than I used to be. You know, a lot of our kids with failure to thrive, especially as related to neglect, fulfill the criteria for failure to thrive fantastically, but they often are well below that bottom line on the growth chart, to the point that it can be difficult to estimate a trend. And it can be difficult also because those percentiles, a lot of them are less than 0.01, and they don't really change until they hit a certain Z-score to increase. So using those Z-scores can help you estimate if there's been any improvement or not, especially for those significantly underweight children. It also can help to estimate the likelihood of things like refeeding syndrome. We know for moderate and severe kids, especially those presenting with a history of significant feeding disturbances within the few weeks prior to presentation, that can be a significant risk for them. So in general, when kids are presenting for concern for failure to thrive related to deficient caloric intake, length and head circumference will be initially preserved. So after the weight drops off, typically we'll see the length drop off over time, and then the head circumference. In regards to kind of if there's decreased length with proportionate weights, that can obviously make things more difficult. But if you have a history of a child being a normal weight and then either being in the same or a new environment and having that steep decline over time, and sometimes these kids don't present until toddlers, they can have significant stunting from longstanding malnutrition. So that can be kind of difficult to separate out as well. But for those kids who also have very low length, we have to consider genetic and endocrinologic causes as a potential source of why kind of their growth is the way it is. In regards to things like decreased head circumference, that's more than what we would expect for their length weight decline. We think of things like intrauterine infections, which most people obviously learned about, torch infections, which are some of them in med school, and then teratogenic exposures and congenital syndromes. So what isn't failure to thrive? And this can be really difficult to tease out, especially if you're not getting a great or particularly truthful history when the child's presenting, and maybe you don't have all of the growth charts quite yet. It can be pretty difficult to determine what is and isn't failure to thrive. But typically for kids who have in utero growth concerns or who are born quite early, they can be quite low, but when you either graph them appropriately on their growth chart or when you monitor their trends and their actual weight gain per day, they actually are doing okay. And yet on the growth chart, it can seem like they're extremely low and they are failure to thrive. So that's something to really consider, looking at the weight for length and looking at their growth velocity to make sure that they actually do constitute failure to thrive, as opposed to just typical expected growth in kids who would present with these underlying factors. Things like constitutional growth delay, genetic short stature can also be confused early on for failure to thrive. So just kind of making sure that we're keeping these things in mind. If they're growing along a curve, even if they're below the second percentile, a lot of people consider that to not be failure to thrive as well. And again, that's going to depend upon that weight gain per day, that growth velocity, how the child's doing as a whole, any underlying medical issues or potentially undiagnosed medical issues that might be going on. And then catch down growth, which is something that I feel like we don't see infrequently in peds clinics, which is where a kiddo maybe is born at a higher percentile and then drops down a couple percentiles, you know, to the 10th or the 15th percentile, but then tracks appropriately from there on. And, you know, they'll have proportionate length, so their weight for length percentile will be okay. They'll be otherwise well. And that just represents chance that they, maybe they started out a little bit higher on that growth chart than their genetic potential would have typically allowed. And then after they're born and they're allowed to kind of subsist, they kind of go down to where they were, quote unquote, meant to be. So the most common cause of the symptom of failure to thrive is going to be related to deficient caloric intake. A lot of papers will cite deficient caloric intake in addition to psychosocial factors as being the cause of this quote unquote non-illness or non-organic failure to thrive. Other things that you'll see in the literature are things like psychosocial failure to thrive. Sometimes it'll be defined as a maladaptive parent-child relationship, serious parent-child interaction dysfunction. I've seen there's actually a myriad of other things that are used to describe this non-illness related failure to thrive, and it's pretty fascinating, honestly. And a lot of the early literature actually cites neglect as being a very rare cause, and they use that word rare. A lot of times they're not defining a percentage, which is difficult, honestly, when you're reading those papers, but they kind of caution not to diagnose neglect because it is such a rare cause of failure to thrive, which I actually thought was kind of interesting because it seems like quite a subjective assertion if you don't have any data to back it up. And it could be due to how neglect is being defined. A lot of what we deal with is a focus on intent, and really intent has to do with a person kind of knowing what they're doing and knowing the outcomes of what they're doing. And a lot of times we really just don't have the knowledge of the individual caretaker to be able to make that assertion. So really how we're defining neglect in our practice and in most CAPS practice is a failure to act and or provide. And that could have a slew of causes, including dependency, where dependency is defined as failure to meet a child's needs through no fault of the caregiver's own. And we'll kind of go into essentially what constitutes dependency, but that is not an uncommon thing that we find, and it can be extremely difficult to separate out neglect from dependency related causes. And doing so typically honestly requires involvement of CPS, which involvement of CPS for dependency is fair game. That is part of a big part of kind of what they do and what they evaluate. But evaluating the home environment is obviously something that we can't do as medical professionals. So we really rely on investigators to help us put the pieces together sometimes when we're considering dependency. Obviously, underlying chronic or acute medical conditions leading to poor intake, maldigestion, malabsorption, increased metabolic demand. Obviously, the ones here are pretty commonly thought of, I think. Pretty much any obviously chronic or acute disease state could theoretically lead to poor weight gain. So they all deserve appropriate attention, especially during that history and physical. I did want to point out physical abuse as a potential cause of failure to thrive because we've seen this before. A lot of times our kids with head trauma, especially those who we think potentially have had abusive head trauma events in the past, which is not uncommon for our kids, especially our severely affected kids presenting with abusive head trauma. Concussive symptoms, increased, lethargy, vomiting, those can all lead to poor weight gain. We know that typically, especially in regards to abusive head trauma, the violence can be progressive. So a lot of times when we're seeing them in the hospital, we kind of assume more or less that that's probably not the first time that's happened to them. So that can contribute to them not really taking in enough calories or processing them appropriately. And then abdominal trauma. A lot of times in our abdominal cases, if it's not acute blood loss that's bringing the child in, it's more of like an intestinal perf or something like that. They can languish at home for quite a while. And we've seen that sometimes, which is pretty scary to see, but they also can present with concerns for vomiting and failure to thrive as well. So of the cases or of the literature that I reviewed, I just put a couple here out of them, but essentially we see a pretty wide swath of neglect considerations with regard to failure to thrive. And again, the literature with regard to actual kind of proportions of neglect within that population are pretty scant. So in one study of patients admitted for failure to thrive, in this first study in 2003, only approximately 7% received a diagnosis of abuse or neglect as the main reason why the child failed to gain weight. Yet other studies cite up to 58%, and honestly, that's one of the lower ones. Some of them are up into the 80 and 90% to be that non-organic and etiology, but either didn't comment on neglect specifically, or they said it was quite rare but didn't give a number. And then in a more recently published study, failure to thrive was attributed to neglect in about 30% of cases, and as a secondary or concomitant cause in another 18% of cases, which I feel like is more in keeping with what we see in our practice as well. So these main factors come from literature that define things like psychosocial failure to thrive and that maladaptive parent-child relationship. These papers also are the ones that say that neglect is a pretty rare cause of failure to thrive. So I thought that was interesting. But these are a lot of the things that are cited, and I'm not going to read them out, but I did want to point out a couple things that kind of you'll see essentially mirrored in the risk factors for child neglect. So obviously mental illness and substance use or misuse. In regards to neglect and also physical abuse, inappropriate expectations regarding child behavior and feeding is a huge red flag for us. So the fact that it was listed as a part of a dysfunctional feeding relationship really kind of piqued my ears up, because it's something that we look for honestly really closely when we're evaluating kids for maltreatment in general. Obviously, concerns for apathy or negative perceptions of the child by the caregiver, which sometimes we can get at just through history and observation. Any like food scarcity, housing insecurity, interpersonal or community violence, those are kind of obvious because they can limit obviously resources, but also the ability to seek resources as well. And in belief in unusual nutritional regimens, I put this in there because this was in one of the papers, but we will see this occasionally. I'll admit it's one of the more rare things that we see, but when we do see it, it can be quite alarming because they tend to be relatively resistant to change for whatever reason. So those types of things really can be kind of concerning. These papers also cite things like infant temperament, appearance, and activity level as contributing to this quote unquote dysfunction as well, which again, if you look at the risk factors for abuse and neglect, pretty much all of these are going to be in that list as well. Which brings me to the point that while a dysfunctional parent-child relationship could be contributing to the child's failure to gain weight, it is also a typical hallmark of a neglectful and or abusive home environment. So it deserves special attention paid to try to figure out kind of what might be going on. Obviously, persistent malnutrition outcomes, so kids who just aren't fed for prolonged periods of time, they end up having persistent short stature and stunting, immune deficiency problems, brain growth and development problems, developmental delays, cognitive issues, behavioral disorders. You can see obviously the more tangible things like anemia and different electrolyte disturbances, all the way to kind of the acute refeeding syndrome type presentation of children who are presenting after not feeding for typically a pretty prolonged period of time prior to presentation. And obviously, if it's due to underlying abuse or neglect, you would consider the adverse childhood events literature on child outcomes as well, which include obviously increased risk of a myriad of medical disorders and mental health disorders. In general, abuse and neglect is not rare, especially in Kentucky. I like these. So this data is from 2018. As you guys are probably aware, we're still #1 for the highest rate of abused and neglected children in the nation, unfortunately. So if you think you're seeing a lot of abuse and neglect, it's because you are, quite frankly. So I like to just look at the numbers in red just to be able to get a better handle. So in general, in 2018, the rate of investigations for abuse and neglect was 47.8 per 1,000. Here in Kentucky, it was 83.2 per 1,000. The rate of substantiated abuse or neglect, so where they were identified to be victims, was 9.2 in the nation, whereas in Kentucky, it was 23.5. So to me, that represents a pretty profound statement and just figures as to demonstrate that we really need to keep a keen lookout. It's one of the more common, medical conditions that we see, and neglect typically is going to be cited as the most common form of child maltreatment. These are the subtypes of neglect. Sometimes sometimes cases will fit into kind of multiple categories, but nutritional neglect is really what we're looking at with regards to failure to thrive. Physical neglect, if it really is just purely a resource issue, obviously could constitute that as well. But typically, we're going to define this as nutritional neglect. In general, child neglect is going to be defined among CAPS, which are child abuse pediatricians, as a caregiver's failure or inability to meet a child's basic needs, resulting in actual or potential harm to the child. So this potential harm can be quite subjective depending upon who you talk to, but it's something that really does need to be considered and could meet the diagnosis of neglect. In general, based on the CAPTA, the federal CAPTA, it's defined as any action or failure to act which causes serious physical or emotional harm or death, or puts the child at imminent risk for such harm. So again, it's kind of sounds like stronger wording, and it kind of is, but it kind of fulfills that same type of idea of a failure to provide, but it doesn't necessarily cite, it's not meant to cite at least a judgment on that particular caregiver. Although failure is not the best word necessarily to be associated with, because it implies some type of personal failure, it's really just meant to delineate a case in which a child's just not getting what they need to do well, or not getting what they need that could lead to potential harm in the future. The other thing that I thought was fascinating is that we see obesity-related complications, especially in young children, every once in a while, but a failure to prevent overnutrition is actually included in this definition as well, which we don't get a lot of consults on, but I imagine happens more than we potentially are recognizing. The legal definition here in Kentucky, I'm not going to read this, but you can kind of go through. So engages in a pattern of conduct that renders the individual incapable of caring for the child. This applies to things like substance abuse or parental incapacity related to medical or mental health disorder, continuously or fails to provide essential care, abandons the child, which we see not unfortunately infrequently, and then does not provide the child with adequate care. So I like this wording, does not provide the child with adequate care. It kind of takes away the failure part of it, wording of it, and it's a little bit more plain as to what we're trying to get at. So intent is something I get questions about a lot. It's not necessarily that I'm being asked specifically about intent, but a lot of times the question, that's the underlying question of what we're trying to get at. And it typically, again, it's going to require inference. Again, most caregivers are reticent to give you, in cases of neglect and abuse, are reticent to give you a true history at all. So getting at kind of the intentions of the individual and whether or not they knew something bad was going to result essentially as a product of their actions is going to be even more difficult to get at. And it's outside of the scope of the medical professional, and it's something that we have to remind the courts and CPS about pretty consistently, just to kind of set that boundary that we are just here to provide an objective definition and an objective consultation about kind of what we're seeing as opposed to what we think is happening. And it is not necessary for the determination of neglect. Again, neglect is often going to depend on the state of the child in one environment as compared to another. So if a parent reports, say, a 4-month-old is getting 30 ounces of standard formula, you don't see anything that would contribute medically to that child not gaining weight, and they're admitted and they get 25 ounces of formula and they gain fantastic weight, obviously that's going to raise concerns for the veracity of that caregiver's history, because not only are they getting less formula, but they're gaining weight fantastically when they weren't at home. I will say, though, as far as intent goes, sometimes it can be helpful in determining the viability of that environment being safe in the future. So say if a child were to be removed, which really doesn't happen super often necessarily in these cases, unless there really is a significant like substance abuse or mental health issue of the family. But if a child is removed, it can potentially assist investigators in predicting the child's outcome if they return to the same environment. You know, if it, and we have these unfortunately these parents that do kind of lock their children in rooms and in basements and things like that and restrict their food and drink significantly and intentionally in that manner, knowing that the child obviously can't eat or drink, and sometimes it can be rather profound. So obviously that unfortunately may represent an environment that cannot be remediated by resources, whether that be therapeutic services, because of the degree to which that intentional aspect of it may have played a role. In general, intent is not going to be super important to our immediate evaluation, though, and typically does not play a part in making our diagnosis. Risk factors for child neglect. This is, as you can see, this is kind of a more basic list, but a lot of these things are going to fall into the same categories as the risk factors for psychosocial or non-organic failure to thrive. The role of dependency. So again, factors through no fault of the caregiver's own that are going to affect their ability to care for a child. Mental illness, medical conditions, intellectual disability, different types of food or housing insecurity, poverty in general, versus neglect. And it's not really versus, it's and or neglect, which represents an omission of care. Typically when we're making a neglect diagnosis, we're trying to weed out if these barriers to care or dependency factors exist. Obviously, it could be a mixture of the two, where we find out that, yes, there are considerable factors that could be limiting their ability to provide for the child, but we wouldn't expect the child to do this poorly given those barriers. And sometimes, obviously, that can be very difficult to ascertain. Or it can be a mixture of the two and an underlying medical disorder, just to make that more fun. And that is not an uncommon thing that happens, and those can present particularly difficultly, but it can also present with a child who's much, much, much sicker than we would typically see. In general, and I'll let Nick do this, honestly, but for the most part, we're going to need that thorough history and physical. Remember to get a really as accurate as possible of a length or height, depending upon the age of the child, weight, and a head circumference. Reviewing existing growth charts and previous growth trends is really going to be important. And the main question you're going to be asking yourself if you don't find a potential underlying medical disorder is, if they are fed, do they grow? So if they have a calorically appropriate regimen that the parent is citing at home and you continue that in the hospital, are you seeing anything that would make it so that the child either needs higher kcals or a different type of nutrition? So things like vomiting, poor weight gain, diarrhea. If you're not seeing those things and the child does beautifully, that's a big concern. Obviously, daily naked or dry diaper weights on the same scale if possible, which can be difficult. Strict I's and O's, and a feeding log by the parent. Sometimes you can use feeding logs filled out by parents in the hospital if they're going to be the ones providing the nutrition, to be able also to gauge their level of interest. Some parents are going to be more averse to doing feeding logs than others, and that can potentially be telling sometimes. And obviously feeding observations, which there are a myriad of individuals who can do that. So there's no one specific assigned individual. In general, when you're assessing these patients, it's good to document. I mean, it's kind of difficult to not document a subjective appraisal. So do they seem apathetic, nurturing, distracted, distressed? But it's also good to cite the objective means of coming to that subjective appraisal. So if the baby's crying and obviously hungry because they haven't eaten in 3 to 4 hours, is the parent just on their phone? Is the parent asleep? Will the parent, even when the parent's woken up, are they going to feed the baby, or are they just going to feed the baby an ounce to get them to stop crying and then go back to doing what they're doing? That's not uncommon, what we see. Leaving the hospital for long periods of times. Obviously, make sure that employment or other children are not the cause of that. But if they're leaving the hospital for long periods of times and they don't have other responsibilities, that can be a red flag. Obviously, early involvement of social work, and then if you have considerations of neglect in these cases, or involvement of our team as well. Evaluating barriers to care. So most of these are pretty logical. So limited finances, limited transportation, difficulty in applying for government support has actually been something that we've been seeing lately, or I've been seeing lately. Mistaken information or lack of know-how. Again, this would not necessarily mean neglect, but it can represent a barrier to care that the individual just doesn't know how necessarily to mix the formula, doesn't know what inappropriate or appropriate nutrition is for a child of that age. Obviously, any caregiver medical issues can really contribute to that child's just overall state, but also nutritional state. So if that parent has cancer or has recently been in an MVC, are they, receiving a lot of care, and do they need a lot of care by themselves? And there's really not a lot of other people to help care for the baby. So really assessing for those familial and friend support systems is important for not only the welfare of the child, but also that family in general. Obviously, inadequate support to care for the child, limiting the parent's ability to find or keep employment. This is not something that's uncommon that we see, and that can be quite distressing to parents, and it can cause them to present sometimes like they are almost like aloof, but and a lot of times they won't tell you like straight out that they're at risk of being fired. Sometimes you really have to ask that question, and then they will tell you honestly. And then obviously interpersonal or community violence, limiting their ability to kind of leave the home and get those things. Strongly consider CPS where no barriers to care are identified and the child gains weight beautifully on the home regimen. Obviously, if barriers to care were identified in the past, sometimes we have, repeat failure to thrive admissions, and they're ameliorated, and the parent doesn't really have those barriers anymore, and they still don't do well. That's significantly concerning. Obviously, in cases where there's significant barriers to care like dependency, and there's no, family or friend supports that are reliable, involving CPS can really be helpful for these families because they can link them into things like daycares and different food programs and things that they wouldn't necessarily qualify for without that involvement. And then obviously any concerns for physical or sexual abuse or other forms of neglect. We're mandatory reporters. Everyone in Kentucky, from the person who works at Kroger to the person sitting next to you, if you're sitting next to anybody. And we are required to report suspected child abuse, and just to have a reasonable cause. So you don't have to have a diagnosis. You don't have to have a ton of quote unquote evidence. But we do expect you to make the report if you do have those concerns. And diagnosing neglect, sometimes it's really difficult to make that diagnosis in the hospital. Sometimes I feel like I need to follow them as an outpatient to see kind of what's really happening. Obviously, there's no set criteria, but if they do fantastically better in one new environment where as opposed to the old environment where there's really no quote unquote reported changes from those two environments, that can obviously be a really good but not necessarily perfect indicator that neglect might be going on. We will come to consensus. So we do staffings every week and we discuss these cases. We discuss all of the cases that we get. So we try to kind of come to consensus about degrees of concern with regards to not only neglect but abuse as well. More often than not, and I think that this is shocking to some folks, but we, in general, our service more often than not does not make a final diagnosis of abuse or neglect. About 30% of the time we do, and 70% of the time we don't, which I think sometimes surprises people. In general, I talked about this, but we might need to follow the family as an outpatient for a while. Sometimes new information will come to light. Sometimes an underlying medical disorder will come to light. Sometimes barriers will be fixed with no improvement or even deterioration in the child's state, which is significantly concerning. And then obviously, a lot of times we really need to consider the barriers to care, which can be quite subjective. And the degree to which it's contributing, which is not an exact science by any, by any notion. In regards to diagnosing neglect in patients with failure to thrive, There are considerable differences among pediatricians and among CAPS, but in general, some things that can happen even just when making reports to social services. Providers can have anxiety or guilt with making those reports. Obviously, there can be a lack of or inaccurate knowledge as to what may constitute possible neglect. Again, if you're relying on that intentional omission of care, that can really skew kind of what you're thinking. And then obviously provider management practices and reliance on laboratory or subspecialist evaluations to make a diagnosis can really either delay or prevent the diagnosis of neglect from being made. In general, a diagnosis of abuse or neglect or dependency is not meant to and should not in and of itself constitute judgment on a caregiver. Obviously, there are social ramifications of reporting families to investigators, some of which are negative, but then some of which are positive. Again, families can receive those necessary services. They go into the home, they see what it looks like, they talk to other people in the home. So what it can allow for identification and referrals for other potential concerns, and the child and or family might have a better outcome. Sorry, Nick, went a little over.
Sorry, I've been talking and I've been muted. You'd think I'd be good at that with as much Zoom meetings as everybody's had to do this past year, but here we are. Anyway, thank you, Jenny. Good morning, everyone, and thank you again for tuning in at this hour on a Friday and for giving us this opportunity. Dr. Green has just done a terrific job of describing the complexities of failure to thrive and nutritional neglect. And now we're kind of going to build on what she's already discussed and talk about how to incorporate those current best practices into the evaluation of these children before we close with a few demonstrative case reviews. Now, way back in medical school, I had a mentor who would tell me almost daily that for just about any presenting problem, the history is the diagnosis. And Jenny kind of alluded to this phenomenon earlier as well, especially with failure to thrive and neglect kiddos. And what he meant by this was that if you ask the right questions, your patients, or in our case, their parents, will tell you exactly what the problem is. You really just have to listen for it. And as complex and nuanced as our failure to thrive patients can be, most of the time the etiology does fall into that non-illness category that Jenny discussed earlier and can be identified with little more than a thorough and careful history and brief period of observation in the hospital with little to no diagnostic testing. This is an approach that lends itself to a timely, targeted, and cost-effective diagnosis. So understandably, then, asking the right questions and asking enough of those right questions is going to be a key factor in establishing the diagnosis of neglect in the setting of failure to thrive. Starting with the history of present illness, the goal here is really to develop an understanding of how and why the child came to be admitted in the condition that they did. Knowing where the child started out from a growth standpoint, we're talking size parameters at birth here, is context that you need when you're assessing their size and trajectory on admission. Another important clue is knowing at what age the child began to falter. And yes, I know you're all probably thinking that this sounds like a great opportunity to flip to the growth chart tab in EPIC. We'll talk a little bit more about that later. Was the decline in growth slow and steady, or was it more precipitous? Was it really a decline or just failure to really take off to begin with? What was going on in the child's life when the so-called turn happened, and has the child had any symptoms besides just poor growth? Trying to get a sense of how the child and caregiver handle feeds can be beneficial, as can gauging the caregiver's understanding for why the child was admitted in the first place. Your HPI is absolutely not going to be complete, though, without a thorough diet history. We need to know, what does the child's feed typically look like? How much are they taking at each feed? What is it that they're taking at each feed? And how often? What sort of changes, if any, have been made to the child's diet, and why? That's a big one. And do they, coincide with the turn or the flip of the growth chart into a downward trajectory? It may also be important to assess for any family or cultural dietary practices. Jenny mentioned earlier that these can be the trickier ones to persuade that get into pretty entrenched beliefs for one reason or another, but they certainly could play a large role in why the child's not gaining weight as well. Of course, the story has to be understood in the context of the child's past medical history. We need to know if there are any current or previous diagnoses that the child has. Are they taking any medications, or were they previously taking any medications? Allergies to foods or medicines also need to be considered, and understanding the medical history of the parents and any siblings, particularly with regard to their growth histories, is important as well. Here's where things start to get interesting, and for a lot of people uncomfortable, and that's the social history, and trying to assess those psychosocial factors that are so often causal or at least contributory to a child's failure to thrive. And though talking about these topics can be a challenge, this component of a thorough history is often where the answers are going to come from, or at least part of the answers are going to come from in failure to thrive and neglect cases, particularly when things like dependency and assessing barriers to care are being considered. It's important to know who the child lives with and who is taking care of them, and when, kind of the rotation schedule of who is taking care of the kid at different parts of the day or different parts of the week, really. Does the child live in one home, or do they spend time in several homes? Is the kid with dad sometimes, mom sometimes? Do they spend time with grandma, aunts, uncles? It's important to know who all is taking care of this kid and how they are kind of rotated through their caregivers. Do the caregivers get along with one another, or is the dynamic somewhat unstable, to phrase it nicely? Perhaps most important in this section of the history, though, is identifying any barriers to care or barriers to other resources that the family may have and their ability to access those resources. Are the caregivers employed? Does anyone receive benefits such as WIC or SNAP? Have they had trouble trying to get those and just haven't been able to get them, even though they have reached out for those? Even assessing for limited access to transportation or even communication. We all have cell phones in our pocket, probably right next to you as you're listening to this, and that's not the case for everybody, even though so many of us kind of assume it's a normal part of life nowadays, and it's can really limit your ability to function and get a kid what you need in this world. And then understanding family support kind of ties in with the family dynamic assessment earlier. But assessing for all these things can reveal hurdles that need to be cleared in order to ensure the health and well-being of the child, which is really what we are all after. When it comes to the physical examination of the child, it's probably not going to surprise most of you that the exam should include, or should be just about as thorough as the needs to be. It will be important to assess all the major systems, cardiovascular, pulmonary, gastrointestinal, neurologic, musculoskeletal. I'm sorry if I've left your favorite system out. I promise it wasn't intentional. But the physical exam for a child being evaluated for poor growth should also include some special attention paid to other things like the integument, talking about any skin lesions that you find, and also about the quality of the skin and also the quality of the hair and the nails. Are they thin? Are they brittle? Is it loose? Assessing subcutaneous fat stores is important, and so too is looking for and describing any dysmorphic features that the child may have. You'll also want to evaluate for any ocular abnormalities, do a thorough check of the mouth and dentition. That can certainly impair a child's ability to eat, and assess for any glandular or hormonal issues that might be going on. The thyroid's the big one, but certainly other hormonal factors can play a role as well. And getting a sense of the child's developmental abilities is also very important to get an understanding for as well. All right, so we've taken our detailed admission history. We've done our thorough physical exam. What should we do now? What should we order? For the observation-focused approach that we've kind of been talking about through this Grand Rounds presentation this morning, current best practice recommendations are actually to order pretty few things right off the bat on a child's admission. Without a doubt, the most important order you're going to place, though, assuming it is safe for the child for you to do so, is that diet order for exactly what the caregivers have told you the child is taking at home. Being able to gauge the child's growth on that home regimen in the controlled environment of the hospital is really critical. It's almost the keystone of the overall assessment. And essentially what we're trying to do is determine if that home regimen works or not. And most of the other initial admission orders are kind of going to support this idea or this goal. Getting those consistent weights, consistent meaning as close as you can to being same time of day, same scale, same amount of clothing. I know that not all of those are possible all the time, but those are certainly things that we should strive for to establish a accurate growth trend. Strict monitoring of intake and output, and it's great if you can get the caregiver to be involved. Like Jenny said, it's can kind of be telling if they are not engaging in the process. And getting calorie counts and really trying to quantify how much the kid is getting, and if it is appropriate, nutritionist or dietitian can help you with that part of it. And all this will generate the data that we need to make that call of whether the home diet is working or not, or should work or not. Another important element of the child's evaluation that should occur pretty early during admission is a feeding assessment. Now, some institutions that do have specific feeding therapists who can be involved for such a thing, but you don't have to have a feeding therapist. Really, anybody on the caregiving team can perform this feeding assessment, including nurses, and physicians, but then also speech pathologists if they're involved, or lactation specialists, especially for breastfed children as well. This feeding assessment, what is it really? It's likely not something that many of you are doing regularly, or if you've really done before at all, but it's also not something that necessarily needs to be as tricky as you might think. Essentially, it's no more than documenting an observed feeding of the child by the caregiver, and you're just going to pay particular attention to the interaction between the two during that feeding. So as you're observing a feeding session, you want to ask yourself questions like, is there eye contact between the caregiver and the child? Feeding time should be bonding time between the parent or the caregiver and the child. Is the caregiver active and engaged in the process? Are they holding the child close with the bottle versus bottle propping, for example? Are the child's cues and signals clear? And is the caregiver picking up on and responding to those? Is the environment free of distractions? Is there a TV on, or is there a cell phone in the parent's hand? Or is the child struggling to eat and swallow? You want to try to get a sense of how that oropharyngeal mechanism is working. Is adequate time being given for the feed? I know it sounds like I'm just listing a whole bunch of questions, and I guess I am. I could go on, but these are the kind of observations that you're going to want to be taking away from this feeding assessment that can clue you in as to why the child might be having such poor growth. And it's important when you document these observations, though, that you try to keep it as objective as you can. You want to write what you see, but try not to project too much beyond those observations. An example of that would be, writing down, frequent eye contact was observed between the caregiver and the child throughout the feeding. Would be a more objective way to write down what you saw. Then, the caregiver and the child looked at each other lovingly for most of the feeding. You don't want to put that interpretation of emotion or feeling there, but you do want to write exactly what it is that you are seeing. Other important elements you might need to consider during the admission are obtaining any pertinent outside records the child may have, including records from the child's primary medical provider or subspecialty providers if they've already been evaluated by them in the outpatient world. This can be of particular importance in cases where the child hasn't had much interaction with our healthcare system, meaning that there aren't many data points on that EPIC-generated growth chart that we mentioned a little bit earlier that can make the child's overall growth pattern a little bit more difficult to determine. You can get those and integrate the data all into one single all-inclusive growth chart that can be a very powerful tool, even if it's not readily available through EPIC. And speaking of which, imaging studies, laboratory testing, and subspecialty consultation are also very powerful tools that can and very much should be used, but only when there's clear indication for doing so, and should not be an automatic, reflexive part of the failure to thrive / neglect workup. So there you have it, everything you need to do in order to identify nutritional neglect in the setting of failure to thrive, right? So let's take a look at a few cases that demonstrate how this can really look in the real world. All right, case one. Our first case is that of a almost 4-month-old little girl who, you guessed it, was admitted to our hospital for evaluation of failure to thrive. She was born with about the 95th percentile for weight, and after some of that catch-down growth seemed to be tracking relatively well until around the 2-month mark. Her pediatrician had been following her as an outpatient, but ultimately sent her to the hospital when she fell below the first percentile for weight. The mother reported what should have been an appropriate feeding regimen for a child of her age, and a preliminary smattering of imaging and lab studies for the girl were pretty normal. On admission, the child was kept on the reported home feeding schedule, yay, and observed, and that's really it. So let's see what happened. So you can see where she started out on high percentile and then caught down a little bit before she really started to fall off. The arrow here is indicating her admission date, and you can see that during that period of observation after that arrow, she starts to march right back up the growth curve. So what really does this mean? Additional history taking did reveal that since the mother returned to work at about that 8-week postpartum point, it's that 2-month mark. Sound familiar for when she kind of started to lose weight there? She and the father worked largely opposite shifts, meaning that they were essentially alternating between one caregiver and the other when it came to taking care of this new little baby. And when it came to the child's admission, the mother was the one that was there, and she was independently maintaining that home feeding regimen that got us that steady climb. So there's our evidence that yes, the home regimen does work, which means that the home regimen isn't really what she was getting at home. So this is an example that is diagnostic of nutritional neglect. It turns out that the father wasn't quite as on top of the feeds when he was on duty with the child at home. And we were able to get to this diagnosis with nothing more than that thorough history. And again, it did involve assessment of those psychosocial factors, but then had that careful observation in the hospital to assess that home feeding regimen. So this is a case that demonstrates one where everything more or less went right. And next I want to show you guys a case where things kind of went less right. And I'll try to pick up the pace here a little bit. So our next case involves a child who's a little bit older, an 8-month-old male who was sent to our hospital by a CPS. A family member who hadn't seen him in a while was worried about his size and reported their concerns. When he arrived, he weighed below that 0.01th percentile. This is a good time where Z-scores might be the way to go. And the only other available data point that we had for him in the EPIC system was that he was about the 45th percentile back at the 1-month mark, so quite a downward slide. The initial battery of testing for this child was reassuring, but the child was admitted for further evaluation, and rightly so. On admission, the mother reported that the child was still primarily breastfed and that he would feed every 2 to 3 hours or so. And his growth chart looked a little something like this. So here you can see our only pre-admission data point, and that long gap does make it hard to truly understand how and when the pattern of decline happened. But turns out mom hadn't taken him to any clinician or any medical provider in that time period, so we weren't able to put together a more clear pattern than that. But anyway, when we do find him, he's all the way down here. With no other data, it's difficult to say just when he began that slide, but the fact that he did slide down is pretty undeniable. You'll also see that just like our child in case 1, though, that after he was admitted, there was a steady rise in his weight after admission. So is this growth chart one that's also indicative of nutritional neglect? And the answer is maybe. So when this child was admitted, he was started on a scheduled formula feeding, which was not the home regimen, and it clearly had the intended and necessary effect of causing sustainable weight gain. And although this weight gain was good for the child, we're always big fans of healthy, happy children over here. The immediate switch to a different diet makes it really kind of impossible for us to definitively assess that adequacy of the reported home regimen, which is tricky in cases of breastfeeding anyway, which in turn means that the diagnosis of nutritional neglect really wasn't one that we could definitively make here. So in this case, our suspicion was, prolonged breastfeeding failure versus possible neglect, but ultimately we weren't able to make that assessment and went down as an undetermined. All right, the last case, and I will really try to fly through this one. This one is a more complex case. Our first 2 cases, the one diagnostic of neglect and the other undeterminable, were both relatively and intentionally simple cases that hopefully illustrated the clear concepts that we've been trying to lay out for you guys. This last case, it's more complex. And when I say more complex, we boiled it down to 4 slides. A case that our final report on was about 25 pages long. So this little girl came to our attention when she was admitted to Our Lady of Peace, weighing only 22 pounds. To put that in perspective, that's about the 50th percentile for an 18-month-old. And she was presented to OLAP by her stepmother for evaluation of behavior concerns that included binge eating, stealing, and hoarding of food, and a violent and destructive nature. She didn't meet criteria from a behavioral standpoint for admission, but they were so concerned about her size and her safety that they ended up admitting her for safety concerns. The kicker is that this kid had been seen by several primary care providers and medical subspecialists over the previous few years to try and figure out why she was so small. Let's just take a look at her growth chart next. So her OLAP admission occurred right here at kind of the tip of the arrow. We don't actually have the data points from OLAP in this chart, but you can see that she was tracking so low for years before she was admitted to OLAP, and you can also see where she wound up heading after CPS was involved. So adding a little bit more history, I know we're right up against the clock, guys. She was removed from the biological mother at 10 months age out of concern for neglect. It was not concern for nutritional neglect, though I want to make that clear. With mom, she'd been tracking kind of along the 25th percentile for weight, but she was removed and she was placed with her father and a stepmother. And in their care, it was ultimately discovered that this child was kept in a bare, locked room for 12 to 14 hours overnight and had limited access to food and water. She was found drinking from the toilet on several occasions when she was allowed to use the restroom, and a whole bunch of other atrocities that I could keep talking about. But for the interest of time, we'll move on from there. But you guys get the picture of the kind of life that this kid was leading there. When she was discharged from OLAP, she was placed in foster care where she kind of paradoxically demonstrated a poor appetite and would tell the new caregivers things like, "Mommy," who's the stepmother, remember, said, "I can't have this or that because I'm allergic." And we did have that evaluated, and she was diagnosed with avoidant restrictive food intake disorder, which she is doing much better from that standpoint. But even with those going on, she still demonstrated steady weight gain in the foster home environment. And it's also worth noting that the behaviors reported by the family kind of when they presented her to OLAP were not seen at all by OLAP staff or in the foster family. We followed her for about 6 months. This is another one that we kind of followed long term before we were able to make the diagnosis. And the child gained as much weight in those 6 months as she did in over 3 years with the father and stepmother. So even though the growth chart shows a similar pattern to the other 2 cases, we've got a drop in percentile followed by steady weight gain. The history that accompanies this chart is wildly different than the first 2, but still diagnostic of nutritional neglect. And it is neglect in the sense that her needs were not being met, which is can be an act of omission, but in her case, the role of intent comes into play and is paramount, really, as satisfaction of her needs was purposefully withheld, making it more of an act of commission. Her case is also a pretty remarkable instance of psychological maltreatment as well, where the relationship between the caregiver and child through repeated caregiver acts of either omission or commission inflicts harms on the child's well-being and is likely to be interpreted by the child that he or she unloved, unwanted, and really undermines the kid's development and socialization. All right, so there you have it. We made it right at 9 o'clock. We've reached the end, and if you made it here with us to the end, thank you for your attention, and I hope you found something from this morning's talk that you'll be able to take with you. Thanks again for the opportunity to speak with you all this morning, and if anybody has a few questions, I'm sure we will be able to stick around and try and get those answered for you. And just so you know, we did back this up with some medical literature. So thank you again. Any takers? I haven't been on mute for a half hour, have I?
Hello, can you hear me? I have a comment.
Yes.
Can you hear me? Yeah, this is Diana Pantelis. I'm a nutritionist and work in genetics, and I actually work on the feeding team here at the developmental pediatrics. But with my work in genetics, we have sometimes tried to involve CPS in some cases, but have had a difficult time getting them to follow through or getting them to see the problem from our perspective. Do you have any comments on that?
So sometimes we have that issue too. And even in those cases where maybe other providers have had difficulty, sometimes we'll have better luck and sometimes we don't. And I can honestly say that it's highly variable, sometimes dependent upon the team and their caseload. I don't have a great answer for you other than if there are continued concerns to continue to make reports, because sometimes it will kick it up to like a specialized team. So I know that that can be difficult, but that is something that we recommend, and continued involvement, repeat consultations to our team if you don't see things getting better. I mean, these are, unfortunately, this happens. There's no cure to it, so to speak. A lot of times we try the best that we can, but really persistence over time sometimes will be the answer to that.
Okay, thank you very much.